Hello, my name is Sangeetha Shah from VCU Health in Richmond, Virginia. I am excited to be here with you today to discuss pregnancy and imaging. Today, we're going to talk about the hemodynamics of pregnancy, share with you the WHO classification of pregnancy, and then discuss specific patient groups. What I'm going to do during this presentation is incorporate imaging of some congenital heart diseases so that we can expand upon the last lecture of vocabulary about congenital heart disease and put it in the context of pregnancy. So many of you know during pregnancy, we have a significant change in hemodynamics. We have a decrease in systemic vascular resistance with lower afterload present. Between the first trimester and the third trimester, we have about a 40% increase in cardiac output, about a 30% increase in blood volume, about a 15% increase in heart rate, and about a 10% increase in stroke volume. This is important to understand, and it's important to also understand that it takes about 6 months postpartum for those to come back down to baseline, which is important when we're treating patients in this population, as well as performing their cardiovascular imaging. The article that I reference at the bottom was recently done, and it was a beautiful article that they did in pregnant women and measured flow during pregnancy by cardiac MRI. And what they showed is that in the supine position, normal females, the IVC flow reduction was by 85%. Flow did get back to the heart, but mostly through the azygos. In the supine position, the cardiac output decreased by 16%. So now when we look at this in a graph-like form that was originally published in 1994, is in the supine position, the heart rate is higher than in the lateral position. The stroke volume is higher in the lateral position compared to the supine position. In supine position, you have a significant decrease in stroke volume, as you see here. And as you would expect, the cardiac output increases in the lateral position and decreases in the supine position. The reason that I'm showing you this is because it's very important when you're imaging a pregnant lady and you may be imaging, your sonographer may be imaging on her back, their IVC will be small. You change them to the left lateral and all of a sudden you can see the IVC. So remember, it's important to know that and to discuss that with your sonographers when imaging. By echocardiography, it's important to remember what's not changed during pregnancy. Your overall EF doesn't change and your pulmonary artery pressures don't change. Remember, we talked about the vascular resistance, whether it's systemic or pulmonary vascular resistance does decrease during pregnancy. The echo parameters that do change are on the left of the screen, and this is ventricular dimensions, the wall thickness, the mass, the myocardial strain, left atrial volume, stroke volume, as we've discussed in the previous slides, mitral inflow, and then important to note, aortic root diameter, which will come up again in our later discussions. Heart disease is a major cause of maternal death during pregnancy. That's why people discuss it, and that's why we need specialists to help with the care of these patients. Why? First of all, there's increasing age of the first pregnancy. Second of all, we have increasing prevalence of cardiovascular risk factors such as diabetes and hypertension in pregnancy. And third of all, the adult congenital population is growing and is getting to reproductive age. This is a little bit of didactic with a little less imaging initially, but it's a good fundamental to understand when imaging patients that are pregnant, as well as if you're taking care of patients. So you can reference the 2018 European Guidelines for Management of Cardiovascular Disease. And there is a WHO classification of 1 through 4. And when you look through it, we go from no maternal mortality with none or mild morbidity to 4, which is extremely high maternal mortality and severe morbidity. So when we look at who has no mortality and minimal morbidity, WHO classification 1, this is uncomplicated small pulmonary stenosis, PDAs, mitral valve prolapse, someone with repaired ASD, VSD, anomalous pulmonary venous drainage, or those with atrial or ventricular ectopy. When we go into WHO2 and WHO3, you can take a look here. I'm not going to read this all to you, but for us imagers, it's important to understand, WHO2 to 3 is mild LV dysfunction, an EF of 45%, between 45% and normal, someone with hypertrophic cardiomyopathy. Marfan's bicuspid aortic valves without significant aortic dilatation, repaired coarctation. In the WHO2, you see Turner's and tetralogy of Fallot, even those who have been repaired. WHO3 moves into where we have significant mortality and severe morbidity. And here you see ventricular function between 30 and 45%. Someone who's had previously postpartum cardiomyopathy with normal LV function now. And you go down through the list and you have moderate MS, severe asymptomatic AS, someone with a systemic ventricle, someone with Fontans. Cyanotic heart disease, you got to be very careful. They can be between WHO3 and WHO4, depending on what's going on, and then other complex congenital heart disease. WHO3 also extends into all our aortopathies. Important to remember Turner's, Marfan's, bicuspids, and tetralogy. And I've listed the dimensions of the aortas that put you into WHO classification 3 based on the disease process. I'm going to turn your attention to Turner's, which needs to be measured for body surface area. WHO4, pulmonary hypertension. So you have someone with cyanotic heart disease and significant pulmonary hypertension. That would be a WHO classification 4. This is extremely high morbidity and mortality. This includes severe mitral stenosis, severe symptomatic aortic stenosis, coarctation, anyone with Marfan's with an aorta greater than 45 millimeters, bicuspid greater than 50. So as you see in these WHO classifications, a lot of imaging parameters are important to know. I'm putting this up there because even though we have WHO classifications, they've narrowed it down to which maternal predictors of cardiovascular events. And here you see things like reduced pulmonary, subpulmonary ventricular function. So your TAPSE of 16 millimeters. You can see that a reduced EF of less than 40. Also incorporated into here is even pulmonary valve regurgitation, moderate to severe. We usually say valvular regurgitation is well tolerated in pregnancy. However, when you're looking at predictors of cardiovascular event, someone with moderate to severe AI or moderate to severe PI, there is a chance of increased cardiovascular events during and after pregnancy. We always want to balance the mother and the baby. We want them both to do well during the pregnancy. So how do we look at neonatal events? Neonatal events are predicted by these following factors of maternal characteristics. And what you'll notice is any mother with LV outflow tract obstruction leads to increased events for the neonate. Included in this is also mechanical valve prosthesis, or any mother whose cardiac output declines during pregnancy, feeding back into positioning, as well as what we will discuss in the future cases of making sure our cardiac output augments appropriately during pregnancy. So let's start with a case. This is a 35-year-old female with Marfan syndrome who presents for an annual exam and for discussion of pregnancy. Here are her echo images, parasternal. You see that she has some mitral valve prolapse or systolic flattening. You get a sense that her aortic root is dilated. There is trivial at best mitral regurgitation and no significant aortic regurgitation noted. You want to take good pictures of the sinus of Valsalva, especially, and then the ascending aorta. Remember, these positions may be different. You want to measure this in diastole from leading edge to leading edge. And her sinus of Valsalva measured at 3.7 centimeters, and her sinal tubular junction was 2.9. To provide you a reference, there is multimodality imaging of the thoracic aorta that gives a lot of details on how we need to think of the aorta with the different imaging modalities. We have 3 imaging modalities to our disposal: echocardiography, cardiac MRI, and cardiac CT, and we need to utilize these in the appropriate manner. Remember, with echocardiography, we're measuring leading edge to leading edge and end diastole. What's a normal aortic root? We have it based on body surface area, 2.0 for a man and 1.7 for a woman. You will notice as the increase in decades, your aorta size increases, and that's within normal. You also can have a change in your aortic size based on your body surface area, and I've listed the numbers below on how to do that. But a 70-year-old man, a 3.8 centimeter aortic root or sinus of Valsalva is normal, with the upper limits of normal being 4.2. For a female who is greater than 70, the mean is 3.4, with the upper limits, if she has a BSA of 1.7, the upper limits is 3.9. When you're measuring CT and MRI, very important for your interpreter to measure all these locations systematically. And what is referenced is that you want to measure at the aortic annulus, sinus of Valsalva, sinotubular junction, just before the brachiocephalic. Some pediatric cardiologists will measure between the head vessels, but then you also want to measure the descending arch around the isthmus and then the diaphragm, and then the abdominal aorta would be at suprarenally and infrarenal. When you are measuring, be systematic in the process and make sure your colleagues who interpret with you follow the exact same algorithm. When you're looking at CT or MRI, you're measuring inner edge to inner edge, which is a little bit different than echocardiography. You need to use multiplane reconstruction, and I will show you in the next slide what I mean by multiplane reconstruction and why it's important. What they are saying is the yellow line is from your sinus to your commissure. The guidelines, the multimodality guidelines, are recommending that you measure from sinus, the red line, sinus to sinus, sinus to sinus, sinus to sinus, and then to present an average. In my practice, I measure sinus to sinus, but list every single one of those measurements in my report, as in certain disease processes, such as Marfan's, you will get enlargement of one sinus without necessarily getting enlargement of another sinus. Multiplane reconstruction. It's important to have multiplane reconstruction and to measure. So what I'm explaining is the solid black line is not where you want to measure. You want to measure at the dotted black line, because that is it is parallel to, it is perpendicular to the aorta, and that's where you want to measure. So the dotted line would be multiplane reconstruction. We usually have to look at the images on 3 planes, axial, sagittal, and coronal, to correctly position our plane on these imagings. So this is an example of how we do it, and these images aren't as crisp as I would like, but serves as an example. And here on MRI, you would angle with the blue line appropriately so that if you were to measure in the blue box, you are exactly perpendicular. And here we measured the sinuses at 3.6, 3.1, and 3.8 centimeters. And then you measure the ascending aorta and you go through all the steps of the various levels that we discussed. Marfan's, this patient is a Marfan's, and the Marfan's webpage at marfans.org has this wonderful Z-score calculation where you can put the patient's height, weight, age, and there's one for adults as well as children, and then calculate their Z-score, which is helpful in not only following the patient, but also for prognosis. I want to introduce you to another concept that I looked into because I thought it was helpful to talk to patients. Is there something called an aortic ratio? And it's the comparison of what is measured to expected for age and body surface area. And it works for 18 to 40-year-olds, where the equation for what is predicted is the one that I list here. So if we were to use this as an example, in our patient, her aortic dimension by cardiac MRI, her sinus of Valsalva was 3.8. If I put her numbers in by predicted, she is 2.7 is her predicted aortic measurement. The ratio of that would be greater than 1.3. And when you look at their article, it was able to show that what is the rate without survival without dissection? And if your ratio is greater than 1.3, you can see you have a 20% risk of dissection in that inpatient individual. And you can see the numbers coming across. Well, if it's less than 1.3 ratio, then your survival without dissection is pretty doggone good. So when you look at this patient, by echo, her sinus of Valsalva measures 3.7. If you were by MRI or echo to calculate her aortic ratio, it would be greater than 20% risk of dissection at 2 years. Her cardiac MRI sinus of Valsalva was 3.8, Z-score of 3.43, which is increased, and her ascending aorta is normal. So how do you talk about maternal risk of pregnancy? We can take the WHO classification and kind of go through that. And she basically falls into WHO 2 to 3, Marfan's or other hereditary aortic disease without significant dilation. She's less than 40 millimeters. So very important. Less than 40 millimeters, dissection is rare in these patient populations, but we need to also then check ourselves and calculate this as her body surface area. So she is 24 millimeters per meter squared. Your risk increases if you're more than 27 millimeters per meter squared. The other thing to always ask your patient is whether they had a family history of dissection, which increases their risk. They've had a previous dissection, or the growth rate of their aorta is greater than 0.5 millimeters per year. What about her neonate? Her neonate's risk is low. She has good New York Heart Association class. She went 14 mets on a treadmill. She has no left ventricular LV outflow tract obstruction. She doesn't smoke. She's not planning multiple gestations. She's not on anticoagulations, and she does not have a mechanical valve prosthesis. What we do need to discuss with her is the risk of transmission is 50% to her baby, and there's a high risk of premature delivery. So based on her numbers, we followed her up with imaging. We discussed medications, lifestyle, and delivery, and long-term risk. We allow her to go through pregnancy. We did echocardiograms every probably 12 weeks for up to 6 months postpartum. Every trimester basically is what we did. The guidelines say you can do it every 4 to 12 weeks. As for delivery, the size of the aorta is very important. So if their aortic size is between 40 to 45 millimeters, then would recommend vaginal delivery. So in this individual at 3.8 centimeters, we would recommend vaginal delivery. And then if it's greater than 45 millimeters, we would recommend C-section. Remember also to counsel that the risk of dissection is highest in the third trimester and up to 6 months postpartum. And the most important thing is, and we'll discuss this again, is the aortic root dilates during pregnancy and it does not return to baseline. So patients will always ask, well, how much do you think my aorta will increase? I'm 3.8 now, what will I get to? And this was looked a few years ago with a wonderful study where they looked at the immediate and long-term impact of pregnancy on aortic growth rate and mortality in women with Marfan's. The great news is that there was maternal no dissections. There was, however, progressive aortic dilatation. Maximum of 5 millimeters during pregnancy, the average about 3 millimeters. So I do tell my pregnant lady that the average growth rate is about 3 millimeters. The neonate risk is of premature delivery, and that's important to recognize as we noted before. Hormonal changes of pregnancy dilate the aorta. She delivered by C-section at 25 weeks due to concerns for the baby. The baby did not have Marfan's syndrome. There were no complications noted peripartum or postpartum. Her aortic root size at 8 weeks after delivery went to 39 millimeters on echocardiography. So gives you an increase of 2 millimeters. When we're thinking of the aorta, I wanted to bring up Turner's briefly. It's 1 in 2,500 live-born girls. You will see this, or you will see some form of Turner's. The classic Turner's is 45XO. Remember to understand the karyotype if some patient comes in with Marfan's. I have had patients who turn out to be diagnosed with Marfan's as they're trying to get pregnant and have infertility issues. The congenital heart disease occurs in 23 to 50% of Turner's, and mostly it's bicuspid and coarctation. The risk of aneurysms and dissections is there. I have noted that it is most with patients who have bicuspid aortic valves or coarctation. It is important to measure the aorta based on body surface area and to measure the rate of progressive dilatation. The article that I'm referencing here at the bottom of this slide is important because they looked at all Turner pregnancies and they're starting to determine that the risk of dissection is actually low in patients with Turner's. So maternal risk is WHO3 for Turner's if their aortic size for body surface area is 20 to 25 millimeters per meter squared. The other way to look at this is the cumulative. If they have a aorta, which is 25 millimeters per meter squared, they have coarctation, then their risk may be higher, especially if they have a bicuspid aortic valve with that. I have again listed the other disease processes associated with aortopathies. We'll move on to another congenital anomaly with discussion of pregnancy, and this is a 28-year-old female with a double outlet right ventricle and demalposed great vessels. Let's narrow this down. We're talking about single ventricular physiology, who presents for pre-pregnancy counseling. So I'm going to point your eyes to the picture on the right first, and what I want you to notice is that the aorta is anterior in this individual compared to the PA. So this is the demalposed that we're talking about. Generally, in normal hearts, the PA is anterior to the aorta. So this is once again the aorta, ascending and descending. When we look here, we have a right ventricle, a large VSD, the left ventricle. We have the mitral valve and the tricuspid valve. And you basically have two atria, but there's an atrial septal defect there. So this heart is functioning as a single ventricle. This is the descending aorta, and this will be the Fontan that will show up in the next picture. This is a beautiful picture. This is what we call a DKS. What is occurring here is because the ventricle is functioning as one ventricle, What they have done is anastomose the aorta and the PA together to make one great vessel coming out of the heart. So you have two great vessels surgically joined called a DKS, I'm sorry. Here, you see this is how we're getting blood flow back into the pulmonary vasculature. You see the IVC coming in through the liver, and this is your Fontan, which is anastomosing to your PA, and here's your SVC coming down to your PA. This is an extracardiac connection. So briefly talking about Fontans or total cable pulmonary connections is the other way to talk about it. I have three pictures here, A, B, and C. Our patient that I just presented to you is C, an extracardiac Fontan. You see it's outside the heart, or outside the atria, I should say. It's within the pericardium, of course. You have a lateral tunnel, and this Fontan is through the right atrium, but it's a tunnel made with a Dacron patch. Then you have the aorta pulmonary connection, which is connecting directly the right atrium, usually through the right atrial appendage directly into the PA. The important thing to understand is as you look at these, you understand the complications that can occur. In the first one, A, your right atrium becomes severely enlarged. In B, you're at risk for atrial arrhythmias. And then in C, this is the least likely to have atrial arrhythmias as it does not develop scar tissue. Now, going to the physiology of this and understanding pregnancy, this is a single functioning ventricle. Your pulmonary circulation, how does blood get there? It's determined by the contractility of your ventricle. So that single ventricle that we have, how well it contracts and the kinetic energy from that. It's based on the transpulmonary gradient and then the intrathoracic pressure. Additionally, you have to have adequate preload and normal to low afterload. So coming back to that preload, in these patients, if they are supine, they're a Fontan and they're pregnant, they're going to cut off their preload, which is going to significantly reduce their cardiac output. So it's important for Fontans to be off of their IVC. When we're looking at maternal risk for Fontans, we kind of group who's high risk and who's low risk. And if you notice in the high risk, an EF of less than 40% of that single ventricle is going to curtail poor outcomes because you need that kinetic energy and the contraction from that single ventricle to help the forward momentum of flow. So EF on there is, from an imaging standpoint, important to know. From low risk, someone that has good functional capacity, New York class 2 or less, those that have preserved ventricular function, our patient had preserved ventricular function, will do relatively well. Here is her echocardiogram, and here's her ventricle, here's her LV, here's her RV, here's the big VSD, and here's your two AV valves. You can either look at contractility of each ventricle by itself or cumulative to help you understand what the ventricular function is. But this is greater than 40% and good. When you are looking at the Doppler through the AV valves, so this patient has, I guess you could call tricuspid regurgitation, which is important to recognize as systemic regurgitation. So the peak velocity here is 5.2 meters per second and 108 millimeters of mercury. Remember, this is not a reflection of pulmonary artery pressures. It is a reflection of systemic pressures. Before pregnancy, if I were to take care of a Fontans, I put them on a CPET to see their functional capacity and quantitate it as best as I can. And what you see in this woman, this pre-pregnancy lady, she had great saturations. She did not desaturate during her CPET, and her peak VO2 was about 25, which this is a normogram that I use, and that is actually at the upper limits of what average Fontans do, female Fontans. So she has good functional class. So if I were to look at her from a WHO classification, she's a 3. Let's go to the right of the screen and basically I'd go through this systematically and say, okay, she is New York Heart Association class 1. Her ventricular function EF is greater than 40%. She has mild to moderate AV valve regurgitation, and then her saturations are greater than 94%. She does not have pulmonary hypertension. I knew that from a previous cath. It would be hard to determine by echocardiography on her what her PA pressures are. When looking at the mother obstetric and neonatal risk, going back to the left of the screen, she is at risk for arrhythmias, heart failure, and thromboembolic events. So these need to be monitored. Pregnancy increases thromboembolic events. This adds to it. Increased prematurity for the neonate and growth retardation does occur as well. So when you are thinking of pregnancy, remember more women with heart disease are undergoing pregnancy. Use the WHO classification to help you kind of systematically go through the patient's risk pre and post pregnancy. It also reminds you what to quantitate as you perform the cardiovascular imaging. Use cardiovascular imaging pre-pregnancy to the best of your ability. Involve stress testing if possible to document functional class, especially if they have complex congenital heart disease. And then remember to explain to your patient that heart disease can be progressive during pregnancy and that to be monitored for at least 6 months after pregnancy. I appreciate your time. I hope this was worth it, and we'll take any questions. Thank you very much.